With diseases, we have to deal with symptoms, experiences, emotions, and feelings. That is something that we have to keep in mind. That we don't see only exams, laboratory exams or radiological exams. You see patients and you examine them. So, I want to thank you all again, and we continue with the first talk.
Hello everyone. It is a real pleasure to be here with you today to dive into the fascinating world of the frontal lobe, one of the brain's most dynamic and mysterious regions. For your interest, I have brought today with me a memorable case study, which will hopefully not only highlight its clinical importance, but also give you a story to talk about with your friends during coffee break. So, before I begin, I would like to present to you today's patient, which I will name Lobe. So, Lobe is a 52-year-old man, and he presents with new-onset apathy, inappropriate flirting, and offensive jokes. Which of the following statements do you agree with the most? So, classic midlife crisis. Recommend taking up a new hobby. Assume he might be bipolar and just refer him to the psychiatrist. Consider a structural brain pathology as a differential. Or recommend a yoga retreat and less screen time to take the edge off. Hopefully by the end of this presentation we will all agree on one answer. So, back to the basics. The frontal lobe is the largest lobe of the brain. It is located anterior, which means in front of the central sulcus, and superior, which means above to the lateral sulcus. It includes several key regions, including the prefrontal cortex, as well as the supplementary motor area. Therefore, it is heavily involved in both primary motor functions as well as higher cognitive functions. The prefrontal cortex that I just mentioned is arguably its most evolutionary advanced region. It's what makes us uniquely, let's say, human in a way. Functions include memory, impulse control, judgment and planning, as well as emotional regulation. Disruption in this area, for example due to a lesion, can result in personality or executive function disruptions. It can be mistaken for psychiatric illness in some cases. I would like you to keep that in mind for the rest of our presentation. So, back to Lobe. It is a relaxing Saturday night at the hospital when a 52-year-old previously healthy man presents. He is brought in by his family members. He presents with 9 months of progressively deteriorating behavior and intense personality changes. His family claims he is not himself. I will just give you some context. Lobe is a respected working man, a father of 3, borderline boring person. But the last 9 months, he's just flirting with everyone, he's making jokes, he's just not himself, as his family says. So, you decide to conduct a neurological exam, as well as a full blood count and a toxicology screen, where you see that essentially everything is normal. So just to basically reassure the patient and most of all the family, you arrange for the next few weeks to monitor him closely and see how it goes. Our patient, to be honest, doesn't seem that distressed about his situations, but to be honest with you, a midlife crisis isn't sounding that far-fetched. So, one random day, Bob is walking down the street, another person is walking towards him. He sees that random person, and he decides to slap him in the face. The other person takes like 2 seconds to realize what happened, and decides to punch him back. As he's punched back, he falls on the pavement, face down. So a random bystander, let's say Lobe 2, decides to call an ambulance. So he's taken to the ER, where he gets an emergency CT scan. Let's say our patient has a really, really strong head, and he survived the impact. There were no problems due to the punch or the hit with the pavement. However, the radiologist saw something weird, and he consulted his physician to order an MRI just to be sure. The MRI showed a left frontal lobe lesion, with a large dural base and a dural tail sign, which are essentially just radiological findings that suggest that this lesion is a meningioma. What is a meningioma? It is a type of brain tumor that arises from the meninges, which are the protective membranes covering the brain and the spinal cord. Specifically, it usually originates from the arachnoid capsules of the dura, which is the outermost layer of the meninges. So, the patient underwent craniotomy and resection of the lesion. This is a surgical procedure where essentially the neurosurgeon, he removes a part of the skull, he opens like a flap, and then he goes in to remove the lesion. What is important to state here is that in these types of lesion, the neurosurgeon will also remove part of the meninges, like the surrounding meninges, to make sure that they won't reoccur, because as I said, this is where they come from, the dura. So, in the next picture, if you don't like blood, maybe close your eyes. You can see the large round mass. This is the meningioma. If you can see number 1, it is the skull, like the bone. Number 2, it's the dura, and under that we can see the brain that is exposed, the frontal lobe. So, after the resection of the tumor, there was a histological evaluation that concluded that this was a grade 1 meningioma. A grade 1 meningioma is the most common and least aggressive form. It is classified as benign by the World Health Organization. They are typically, so I will show you some histological findings. The first arrow in picture A, it's like a little whorl. Excuse me. It is a meningothelial cell whorl. And something else that is common in picture B is to see the nuclear clearing, which is up with a black arrow, and below you can see the intranuclear cytoplasmic pseudo-inclusions. Don't worry too much about these big words, they are just histological findings in grade 1 tumors. Most of them are benign, meaning grade 1, and around 5 to 7% can also be grade 2 or grade 3. Grade 2 is basically an intermediate situation, and grade 3 is malignant. So, before I let you guys go, I have a final question. Would you have dismissed this patient before obtaining the incidental radiological findings after he was punched? I think we all know the most probable answer. Of course, it is impossible to give expensive radiological exams to each patient that presents with such findings. Like, hey, you're not feeling yourself today, let's give you an MRI. This is not how it goes. However, it is good to have structural brain abnormalities in the back of our heads as physicians, since we have the opportunity, for the small number of cases that this is actually the case, to make a big difference in their life. By the way, Bob did improve after his surgery. He was just fine. I'm not sure his family will ever recover from what they witnessed though. On a lighter note, if your friend ever starts oversharing randomly on Instagram, picking fights in traffic, or hitting on waiters, or even expressing the need to kill their coworkers, maybe it's not their personality. Maybe it's just their frontal lobe. Thank you very much.